Um, I will now go ahead and introduce our speakers. So our first speaker tonight is Dr. Delan Devakumar. He is a public health doctor and an associate professor in adolescent and child health at the University College London. He's also our chair at the International Child Health Group. And he's also the current lead for adolescent and child health at Lancet Migration. Our second speaker of the night is Dr. Amy Stevens. She is a public health trainee doctor in Yorkshire with an interest in migration. She's currently working for the WHO Quality Improvement, for Doctors of the World UK, and also for Bevan Healthcare. Bevan Healthcare is an enterprise that provides NHS primary care and well-being services for inclusion health populations, including refugees and asylum seekers. Okay, so if everyone's ready, I'll let Dr. Devakumar start us off.
Thank you. Let me share my screen. Can you see that?
Yes, we can see it.
Thank you. Thank you, Daphne, for organising this session today. And also thank you to Becky, who is there in the background, who's helping to run things. As you mentioned, my name is Delan Devakumar, and I'm based in the Institute for Global Health in UCL. I'm going to talk briefly, giving an overview of migration and child health, talking a bit about migration generally, a little bit on the numbers and focusing on certain groups of children, and then briefly about the health system, and then hand over to Amy, who will give a much more specific talk about the UK and the UK context. I guess both Amy and myself are similar in that we trained in pediatrics first and then public health, and largely this is a public health perspective on migration and child health. So the first thing to say is that migration is incredibly common. Migration is a reality. About 1 in 8 people in the world are migrants. And people have always moved, always will move. The increase in communications and technology as well as transport allow people to move more easily. So that has always happened and always will. But what we're seeing nowadays is that those in positions of power can restrict or restrain people from moving, can incarcerate people who do move. And there is increasing discrimination towards migrants, xenophobia towards those who are from somewhere else. And this is a profound determinant of health and affects someone's health and well-being, and has effects on their mental health as well as physical health. And particularly for those people who are in vulnerable situations, who are in transit in difficult conditions, migration can be very detrimental to health. And I guess this is happening across the world. We can look within the country where I guess most of us are based in the UK. We've seen this recently in the Brexit discussions. Brexit wasn't about migration, but there was a lot of xenophobia underlying some of the discussions and rhetoric around migration. We see Nigel Farage talking about the hordes of people coming from Syria, from Turkey into the European Union. We have this, I don't think we ever got £350 million a week back from the European Union, but a lot of it was about those people coming from somewhere else and using the resources within this country. This has happened in the Americas, Donald Trump talking about Mexican migrants bringing disease to the US. We have Jair Bolsonaro in the bottom corner, the president of Brazil, who, in a quote, he talked about people from Haiti, from Iran, from Bolivia. He described them as the scum of the world coming to Brazil, the scum of the world and their children coming to Brazil. So incredibly divisive rhetoric coming from these leaders who are seeking to divide the populations to gain political advantage, but scapegoating, demonizing migrants. And while there's often a lot of sympathy towards children, a lot of desire to help children, children are also demonized in the same kind of way. This is from a tabloid newspaper in the UK, where a group of adolescent boys were pictured here in the newspaper with these computer ages added, saying that this person is 35, this one is 38, completely artificial ages, and attached to these people who've come to the UK. And the whole idea behind this is that migrants are a burden on services. They take away jobs. They are actively making this country worse, whichever country that is. And as I say, this kind of rhetoric is there across the world, in most countries in the world, in fact. The fallacy of this is that it isn't true that when migrants move to a new country, they're mostly young adults, mostly who are going to work. And what happens is that the economy doesn't, they're not replacing someone's job, the economy grows. This is the lump of labor argument, where when people move to a different place, these economies get bigger and these places become more prosperous. Migrants in the UK, they contribute to the NHS in particular. We see around a third of doctors in the UK gain their qualification from another country. The NHS survives because of migrants. And we've seen, particularly in the pandemic, a shortage of healthcare staff because of some of the barriers to entry. So thinking just briefly about the numbers of migrants, there are approximately 281 million international migrants, and these are 2020 figures from IOM, the International Organization for Migration. And that's around 3.6% of the world's population. This number has gone up a little, but to be honest, it hasn't stayed. It was high, it went down, and it's going up again. Usually when people talk about migration, they talk about the migration crisis, that the numbers of migrants are increasing dramatically. But if we look overall as a percentage of the world, actually this number is pretty small. And mostly people move to countries next door to the country that they're in, rather than move across the world to other parts. Most of the people who move tend to be labor migrants, moving for jobs. Sometimes they move for a certain amount of time, move back. This could be summer jobs to a different place and back, or it could be moving for a number of years. But what we find is that actually the number of internal migrants, these are migrants who move within a country, is about 3 times as many. So the last estimate, which is around 10 years ago, estimated 740 million internal migrants in the world. When we look at particular populations, forcibly displaced people, people who are forced to move because of some degree of coercion, there's 84 million forced migrants, of which 27 million are refugees, 48 million internally displaced people forced to migrate within the boundaries of their country. And these numbers vary according to the conflicts that are happening at the time. I think Amy will describe some of the definitions around these, but refugees have a particular legal status according to the 1951 Convention on Refugees. The other group here is modern slavery. So around 40 million people are considered to come under this modern slavery category, which includes child trafficking, but also other groups such as child marriage. So if we think about child health in particular, I think it's important to start by saying migration often improves lives and improves health, and that most people who migrate move to better conditions and their health gets better. Children are also quite resilient in that they are adaptable, they can learn languages quickly, they can speak in the way that the native population speaks, and often they can integrate very well into a new environment. But migration, the conditions around migration can severely affect the health of a person in the population, and that can be shaped by each stage of the migration process. Children in many ways are similar to adults in the determinants of health, but there are specific things around their age. A newborn baby is very different from an adolescent child, or an adolescent. And there are these critical windows where development happens more rapidly and is, I guess, in some respects more important So we think about early childhood, we think about adolescence, where systems, biological systems, social systems are developing very quickly. It's also very different according to your abilities. A child with cystic fibrosis or learning difficulty could find the migration process very different to another child. And then the genders of the children. And childhood, adolescence is when you're finding out about yourself, you're learning about your own gender. And certain groups can also face additional stigmatization, this intersectionality between being a migrant, being from another group as well. And also in terms of a health system response, there are specific things important for children, immunizations. How do you deal with children who are moving across multiple borders? How do you keep their immunization record up to date? How do you monitor this child's progress? Thinking about child protection, children who are in difficult circumstances, and then integration with other services and systems, education in particular. So this diagram was produced by Public Health England that describes the health of refugees and migrants. And it divides into these different circles. So the country of origin, the disease profile of that country, the economic and social conditions that someone may live in, the migration journey, and I'll come back to that in a moment, but the stages of migration and what happens at each stage. And then they put the culture and ethnicity, and I would probably put these in inverted commas, in that there are certain genetic disorders that are more common amongst certain groups, but it's usually the conditions that someone lives in, the environment, the jobs and access to healthcare that someone has that determines their health, rather than an innate susceptibility. So focusing on the migration journey, and this was taken from our Lancet Commission paper, if we think about these different stages of origin, of transit, of destination. So origin was described in the previous slide, the disease profile, whether someone's moving from a war or from a disaster area. And then the destination, I think Amy will talk much more about that in terms of the health system response. But the other key phase is this transit phase, and the transit could be very short. It could be hours moving across a border. You could move and get stuck at a border place. You can get stuck offshore. Australia, for example, has these centres in Nauru, away from Australia, where migrants are kept. And you might have these longer term transits that you move to somewhere, you move back, you move there again. You could go to your destination and move back. And this process of migration can take years, not the simple plane flight that someone might take. IOM has described the conditions of the journey, hygiene, availability of food, shelter, injuries, all these different conditions, and children can be particularly susceptible to certain conditions, the newborn baby to hypothermia, for example. So then thinking about the different groups of migration. So I want to talk a little bit about forced migration. And this is where people may be fleeing conflicts and wars and disasters. We have about 85% of the world's refugees actually living in developing countries. And this idea that all these people are coming from Syria, for example, to the UK, this really isn't true. Most people move across the border to where they are living. So most Syrian migrants will move to Turkey, to Lebanon. I should say that these numbers are before Ukraine, and it's estimated, last I saw, around 2 million people have fled Ukraine, mostly across the border into Poland. So I think Ukraine probably would be one of the top countries at the moment. The others depends on the particular crises at the time. So Syria, Afghanistan, Myanmar, the hundreds of thousands of people, Rohingya people across the border in Cox's Bazar and Bangladesh. And the idea of where refugees move has changed a lot, in that the majority live within urban areas. They don't live in camp settings, as you may imagine. They're integrated into populations. They're working within populations. And a lot of children are born as refugees. Around 1 million children were born as refugees, according to UNHCR. And these forced conflicts can result in protracted refugee situations, thinking of the Rohingya people, thinking of the people displaced across the border in Lebanon, and what is happening in Europe right now. This could go on for many years to come. And here's just a picture showing the main areas where people move. So related to the Syrian conflict here, Afghanistan here, we've got Venezuela here, so people moving across the borders. And I think we'll probably see a very big circle here around Ukraine, moving to Poland and other countries nearby. I think it's obvious to say that wars and conflict are bad for children. I think that makes sense, but this review by Aisha Kadir et al. From a few years ago reviewed 151 studies, and it just showed the extent to which war is terrible. It affects mortality, injuries, environmental exposure, exposure to healthcare, experiences of violence, torture, sexual violence. There are so many ways in which conflicts can affect child health. And if we think about those people who are in camp situations, exposure to infectious diseases, particularly respiratory diseases, diarrhea, measles, and further exposure to violence within the camp situations. And thinking about this presentation and also Ukraine recently, it reminded me of some work I did a few years ago that described the intergenerational effects of war. It doesn't only affect the children who are here now, it will affect their own children and probably their grandchildren as well. We see the consequences of the Holocaust still being played out in populations today. So these conflicts that are happening and the effects on the children will last for years, decades to come. The next group I want to talk about is trafficked children. So these are children who are recruited, transported, or transferred across a border for the purpose of exploitation. And there are a lot of these children. There's around 1 million children per year who are trafficked. And this varies a lot, usually for some kind of work, but it varies by their age and gender. So young children tend to be trafficked for adoption, adolescent girls into the sex industry. And this, I saw the fact that this is one of the most profitable forms of criminal activity. I think it's the third most profitable form. It's a huge industry of human trafficking. And it has profound health consequences. If we think about people moving into the sex industry, infection rates, violence, emotional, psychological trauma that they face, and all forms of labor, it could be environmental toxins, it could be injuries that these children are facing who are working in these different environments. And often they tend to be the most vulnerable to begin with, the children who are trafficked, who have fewer protection factors, people around them to look after them. The next group are the unaccompanied minors. So these are children or adolescents who are separated from their parents or legal guardians. We did a review, my PhD student, Susanna Corona-Maioli, who described the different studies around unaccompanied minors and found numerous health, physical and mental health conditions. There was a study of dental caries where approximately 2/3 of the adolescents had dental caries. And again, I think Amy will talk about this in terms of how we respond. But, if you are a health professional in the UK, you need to think about the conditions that these young people may have been in, and specifically look for dental caries, for example, or try to find out their exposure to violence and the trauma that may be lying underneath. Thirdly, undocumented migrant children. So these are children who lack the documentation that shows their regular migration status. Some work led by Dr. Neil Russell showed that in the UK, there's about 120,000 children in this category, half of whom were born in the UK. And while we rightly laud our NHS as being this sort of model of healthcare around the world that's free at the point of contact, it often isn't free at the point of contact for some groups, and undocumented migrant children are one of those groups where they are charged higher than the usual tariff, 150% of the NHS tariff. for hospital care. Primary care is free, but hospital care is charged. And any deaths can be transferred to the Home Office. The Home Office can be notified. So what does this mean? Well, it means the children are not treated for conditions that they should be treated for. The parents delay seeing their doctor because of fear of going to the health service. Antenatal care is charged, and the average cost is around £6,000 per delivery. Modern slavery isn't charged. So if you're a child who's been trafficked, that's not charged. But often these children are not obvious. It's not obvious who has been trafficked. And honestly, most people don't know the charging regime. Most health professionals don't know who's charged and who isn't. And it also leads to a wider effect on the population. It leads to racial stereotyping. I mean, I've had one of these letters myself. My son was born in the UK as a British citizen. He shouldn't be charged, but we received a letter asking about whether we should be paying. The final group I just want to mention are the children who might be left behind when parents migrate. So this is a systematic review we did a few years ago, and there are huge numbers of these children. We don't really know how many, but China has of the order of 60 million children who are left behind. So parents move away to work and the children often stay with grandparents or with the other parent. And the idea is that moving away, you get increased income. It should improve health. But what we found in this review is that a large review, mostly based on studies in China, so mental health conditions, depression, anxiety, and suicidal ideation tend to increase 50%, 80% higher. I think suicidal ideation, there were only a couple of studies, so I guess that's a little bit more uncertain. Nutrition, wasting and stunting both increase as well. And I guess it's fair to say that the majority of evidence comes from China, so that's where these results are most valid. But, and also that most studies are cross-sectional in nature, and we need more longitudinal studies to be able to follow up children. But it really doesn't seem like migration improves health. On the contrary, it seems to make the health of those children worse. So finally, this idea of denying entry to migrants on the grounds of public health protection isn't supported by evidence. And it's what we have to do is design a healthcare system that works for migrants, that prioritizes children, that is child-friendly, that can integrate migrant populations. And this is good for the whole population, not just for migrants. Something that's culturally, religiously sensitive, that works for the local population, that we have mechanisms of financial protection so the migrants aren't excluded from the health system. And then particularly for child protection systems that can be designed to support migrants, that can manage these different phases of migration and think about the trauma that they may have faced, think about these specific groups, unaccompanied children, undocumented children. And this is supported by sort of international doctrines and rights documents, that the global compacts, the UN, the big UN documents on migration that was signed in 2018, the end of 2018, talks about being child sensitive, upholding the principles of the best interests of the child at all time. The UN Conventions on the Rights of the Child, Article 24, children should enjoy the highest attainable standard of health. The WHO framework around migration talks about guiding principles for promoting the health of refugees and migrants, the Sustainable Development Goal, leaving no one behind. We have all of these international documents, rights instruments that countries such as the UK have ratified. But these conditions still happen, as Amy will describe in a little more detail. So finally, and this is from our Lancet Commission on Migration and Health, there's a quote from our editors, Jocelyn Clark and Richard Horton. The moment for migration is now. Migration is our reality and our future. It needs to unite rather than divide us. And that's what we have to do as health professionals. We have to make the system work to improve the health of migrants so that we get the positives but not the negatives. And just finally, if you are interested in these topics, these are two organizations I'm involved with, Lancet Migration, which followed on from the Lancet Commission on Migration and Health, And then the other group I started, Race and Health. So this focuses particularly on discrimination and xenophobia and racism, which many migrants face. So do have a look at these websites, subscribe to the newsletters, podcasts, etc. And finally, maybe, Daphne, I might leave this till the end just to talk about our group, the International Child Health Group.
Yeah.
Come back to that. Thank you.
Thank you. I think Amy, whenever you're ready, Dr. Stevens.
Sure.
Thank you. I'll just hang on a minute for my slides and then.
I'll share your slides now.
Thank you. So I'm going to focus more on specifically on child refugees, asylum seekers and undocumented migrants who have arrived in the UK. That's because that's what my experience is in working with Doctors of the World UK and also for Bevan Healthcare. So next slide, please. So first of all, I just wanted to go over some of the definitions, because although we frequently discuss asylum seekers, refugees and undocumented migrants in the same context, there are important differences between them in terms of their legal rights, but also their public service entitlements. So asylum seekers are persons who've departed their country of origin and officially applied for asylum in another country, but they're waiting a decision on their request for refugee status. And the number and demographic characteristics of new asylum seekers reflect global insecurities happening at a particular time, which Delan's alluded to as well. Refugee status is awarded by the Home Office in recognition that a person meets the definition of a refugee as given by the Refugee Convention, and that definition is on the slide. And undocumented migrants are foreign-born migrants who do not have the right to remain in a given country. That includes people who've entered the country what would be considered illegally, people who've been trafficked here against their will, refused asylum seekers who've remained beyond the legitimate time period, and also children born in the host country to undocumented migrant parents. Next page, please. So the graph here shows the number of people who claimed asylum, positive initial decisions and refugees resettled per year in the UK between 1979 and 1921. And the drop and dip at the end as it ends in 2020 is likely related to the reduced travel during the pandemic. If we were to carry on the graph, we would likely see an increase over the past 6 months or so since travel's resumed, and also due to the Afghan citizen resettlement scheme. Next slide, please. So this chart shows the number and nationalities of asylum applicants over time. And again, this will reflect global conflict and insecurities. And next slide, please. And then this graph shows the same, but in more detail. And also, I just think it looks fabulous. It's really small on here, but it's worth looking in more detail if you have time. And it's part of the House of Commons library, so you'll be able to find this online. But the different colours represent different countries that people have originated from as part of their journey to the UK. Next slide, please. So the asylum process in the UK is strictly controlled and complex, and it's difficult for people seeking asylum to provide the evidence required to be granted protection. The decision-making process can take years, and around 50% of claims are rejected. And this state of limbo and future uncertainty has a significant impact on individuals' mental health and well-being and their ability to integrate. So you can see from the graph that people arrive in the UK, and then they can apply for asylum. The government did say they were going to stop holding children in detention centres during this application, but it's still happening in some cases, but many fewer children than are in that situation now. And often these asylum claims are actually processed in the community. So they undergo screening questionnaires and asylum interviews. And then based on that, they can either be awarded refugee status or humanitarian protection or discretionary leave to remain, or unaccompanied asylum seeker child leave to remain, or you can have your application refused. And at that point you can appeal, or you may leave the UK. And again, there's an appeal process. If you don't leave the UK in the time period that you're given to leave, you become an undocumented migrant. And another way of becoming an undocumented migrant is if you arrive in the UK and then choose not to go through the asylum process. I think if you click again, Delan, it'll show some, yeah. And if you click again, please, it should show the other one. So this is just some figures. So it's estimated that there's over 66,000 child refugees in the UK. We don't know exactly, because once somebody's got a refugee status, we don't tend to collate cumulative figures for that. So we don't know if people are staying or moving, for example. There's estimated to be 120,000 undocumented child migrants. Most of them are thought to be in London, and many of them will be children born to undocumented migrant parents. And then the other figures that aren't on here. So in 2020, child asylum seekers who are dependents, they arrive with family or guardian, there were 5,338 new asylum claims, but there are many more thousands of children who are already in the asylum system awaiting outcomes on their claims. And half of these dependent children are under 5 years of age. And then we've got the unaccompanied asylum seeking children that Delan mentioned. And in 2020, we had 2,773 unaccompanied asylum seeking children making claims in the UK. 91% of them are male, and that's common year on year. The top nationalities in that year were from Sudan, that was 18%, Afghanistan, 16%, Eritrea, 13%, Iran 12%, Vietnam 11%, and Iraq 7%. As Delan said, that would be different now because we're seeing different insecurities across the globe. Most unaccompanied asylum seeking children are aged over 16 years. So in 2020, that was 78% of them. 20% were aged 14 to 15 years, and 2% were under 14. Next slide, please. So we need to understand a child's life experiences in order to recognise their health needs. And many migrants have fled war and conflict, persecution, natural and environmental disasters, and famine. I should say, when I'm talking about migrants in this talk, I'm talking about refugees, asylum seekers, and undocumented children rather than economic migrants. So most forced migrants come from low and middle income countries with weaker health systems, poorer health indicators, and risk of endemic diseases. And many have endured long and dangerous migration journeys, overcrowded refugee camps, exploitation by traffickers, and they've often had limited access to adequate food, sanitation, and healthcare. Next slide, please. And these life experiences make migrants much more vulnerable to certain physical and mental health problems than the general population. And Delan's already talked about all of these, so I'm not going to cover them again. I think I just wanted to highlight, just to be really aware about the sexually transmitted infections. So STIs may be a consequence of rape, sex work, or consensual sex without access to condoms. And there was a study done with 100 unaccompanied asylum seeking children, and 32% of them reported having been raped at least once, and 6% of these were boys. So although it's a very sensitive conversation to have, it's just to be particularly aware, particularly amongst unaccompanied asylum seeking children, of these risks. And also, I know Delan had a slide that mentioned female genital mutilation, but just to say that's more common in certain parts of the world, so places like Eritrea and Sudan, and health consequences of this, things like bloodborne viruses, UTIs, sexual function problems, fertility and obstetric complications. So just be aware that they might need referral to specialist services, which do exist across the UK. And also just to be aware that children who come from countries where it may be part of the culture to practice FGM may be at continued risk of this happening to them in the UK. So children who haven't yet had FGM. So it's just to consider that from a safeguarding perspective as well. And again, there's resources to support you in managing those situations. So just wanted to highlight a couple of migrant health guides, which you might find really useful. And at the end, I'll put some links in the chat as well. But PHE, or what's now known as OHID, and the RCPCH have produced migrant health guides, which are pretty useful for clinicians treating this population, and I will share those. Having said all of this, many migrants arrive in the UK in relatively good physical health, but health problems develop as a consequence of immigration policy, living conditions, and barriers in healthcare access. And we're going to talk about those for the rest of the talk. Next slide, please. So the post-migration factors that influence, have we jumped a slide? No, we haven't. Oh no, yeah. So the post-migration factors that influence health needs include things like the long and complex immigration process, which can take years, and insecure asylum status is associated with higher depression scores. Most unaccompanied asylum seeking children are given leave to remain until they're 17 and a half, and that's when their status is reassessed. But these uncertainties about their future really affect a child's education, their ability to integrate, and also has a massive impact on their mental health. As mentioned, some children are still held in detention centres, which has been shown to have adverse health outcomes. Children have to adapt to new cultures and new languages. Parents are unable to work, which obviously has implications for poverty. Many experience delayed access to education. There's loss of identity and status for migrants, lack of family and community support, integration challenges, poverty and poor housing, which we're going to talk about. Many experience racism and discrimination. Digital exclusion is also a huge barrier in terms of accessing services, and that's really had a spotlight shone on it during the pandemic. And also finally, and most importantly, perhaps in some ways, the barriers to healthcare despite all these increased health needs. Next slide, please. So as Delan mentioned already, England's immigration approach has been driven by a rise in populist radical right policies, and they're at conflict with commitments to human rights and vulnerable populations. And this political approach is exclusionary, and it's contributed to the widening of health inequalities experienced by migrants in this country. And in hand with this is the media's almost unanimous negativity towards migrants, with frequent portrayals of asylum seekers as deceitful freeloaders. You have all seen these headlines. Austerity has resulted in deficit reduction policies, which involve budget cuts to public services and welfare provision, and this has widened health and social inequalities experienced by the most vulnerable groups in our society, which includes refugees and asylum seekers. And then throw on top of both of those things the COVID-19 pandemic, which we know has further exacerbated all of these inequalities that they experience. Next slide, please. So the right to health, irrespective of an individual's legal or administrative status, is enshrined in numerous international treaties which have been ratified by the UK and which Delan has highlighted. And the government also has a duty of care to all children, irrespective of immigration status, as defined by the National Children Act. However, English government immigration policy impedes translation of these treaties and acts into practice for some children. So the government's hostile environment policies were made law in the Immigration Acts of 2014 and 2016. And these policies are designed to deter illegal immigration by firstly limiting migrants' rights, access to services and welfare benefits, and secondly, by integrating immigration controls into public services. And many of these policies impact the wider determinants of health, and the following slides give a few examples of this. Next slide, please. So the Children's Society estimates that many thousands of child migrants are living in poverty as a consequence of low-level support. So asylum seekers aren't allowed to work, and they have no recourse to public funds. Those that are destitute can apply for housing and a cash allowance or payment card equivalent of £39.63 per person per week, and that's less than those who are in receipt of universal credit. For refugees, once you've got your refugee status, any asylum support you're receiving gets axed after 28 days. And that's because you're entitled to claim the welfare benefits that you or I could claim. However, you need a national insurance number for this, and there's reports that that can take up to 28 weeks. And there's Home Office delays in issuing identity documents. And in the interim, employers and banks often don't recognise the kind of interim identity that new refugees have. And that's when you see people really falling through the cracks and at high risk of destitution at this point. Next slide, please. So the association between poor health and deprivation is undisputed, and I'm sure you're all very familiar with the impact on like physical, psychological problems, and also on behaviours for children as well. Next slide, please. So in terms of housing, this is a big one. So initial accommodation centres are the usual first accommodation for any asylum seeker who asks for support. And the Home Office's target is to move people on from this initial accommodation to dispersal accommodation within 35 days. But a lack of dispersal accommodation and the pandemic has seen many asylum seekers stuck in initial accommodation for many months. And as these initial accommodation centres have become full, they've started using contingency accommodation, which has been provided to manage the demand. So thousands of asylum seekers and newly arrived refugees, particularly from Afghanistan recently, are currently housed in contingency accommodation across the country. These are often in hotels, certainly in Yorkshire that's the case, but they have also included former armour barracks in other parts of the country. So this contingency accommodation is not appropriate for long-term stays, and it impacts the health and well-being of people housed there, and it really hinders their recovery from any trauma that they might have experienced. So one man I spoke to described living in a hotel like being a prisoner, and he was afraid to take exercise in the local area due to the racism he had experienced when he had gone out. And also residing in shared accommodation increases the risk of exposure to COVID-19, as it's much harder for people to socially distance and to self-isolate. And there have been outbreaks in many settings housing asylum seekers. And the most notorious was Napier Barracks in Folkestone, where almost half of the residents, 198 people, contracted COVID-19 in January and February 2020. Since then, it's been inspected, and inspectors have delivered a damning verdict on COVID protection, fire safety, and the living conditions. None of the residents who were housed at Napier who responded to a survey by the inspectors had felt they'd been kept safe from COVID-19. And about a third of respondents said that they had had mental health problems, and another third said that they had felt suicidal. People at high risk of self-harm who were housed at Napier were located in what was described as a decrepit isolation block, which inspectors have considered unfit for habitation. And residents who may have been children were also housed in the same block pending an age assessment, and that links back to what Delan was talking about. And there have also been cases of children being wrongly treated as adults and housed in adult hotels, which not only is a safeguarding risk as a child being housed in an adult hotel, but it means they also can't access the support that children otherwise are usually provided with, or at least entitled to. So asylum seekers, when they're moved on from this initial accommodation, are subject to the government's dispersal policy, whereby they're accommodated across the country without consideration of personal circumstance or preference. The idea being that you share them out amongst local authorities so that no one local authority has, I'm going to use the word burden because that's how the context in which it's talked about, but it can be expensive and challenging to house certain populations. So rather than the Southeast taking all the children, the idea was that the children are housed across the country. However, frequent relocation and separation from established social networks or ethnic communities reduces opportunities to form support networks, it heeds integration and increases social isolation. And the frequent relocation also affects healthcare access because of barriers associated with GP registration, and it also impedes continuity of care and follow-up for things like screening, immunisation, treatment for existing health problems, for example. So dispersal accommodation is generally a house or flat in a residential area, often shared with other asylum seekers. And that's where asylum seekers reside whilst they're waiting for their asylum claim to be processed. A 2017 House of Commons report into this privately contracted asylum accommodation described, and this is in their own words, too many placements as substandard, poorly maintained, and at times unsafe. And then personal accounts have suggested this is still a problem. So I'm just going to read to you a quote that was taken from an interview that I carried out with an asylum seeker from El Salvador. And he said, "At the beginning, it was not okay. It was dirty and the heaters had a problem. I fixed them, and I fixed water pipes that were leaking. I fixed a lot of things here. When we first came, it wasn't a really good place to live, not for my daughter. The flat looked secure, but it wasn't. We used to have 2 neighbours. They used to drink a lot, and they used to be knocking the doors during the night time, really late in the night. And during the day, I was afraid to go out and leave my wife and my daughter by themselves because they didn't speak English at all. And I thought if someone knocked the door and they opened it, then something bad could happen. I've also fixed the main door because you could open that from the outside, even though it was locked. So I fixed a lot of things by myself. I kept calling migrant help, that's the Home Office helpline, at the beginning, but I never got an answer from them." And similarly, the issue of housing was frequently raised by forced migrants interviewed by researchers from the University of Birmingham for the Sereda project, which was supported by Doctors of the World. So there were multiple accounts of unclean accommodation infested with mice, rats, and bedbugs. So I should say that this report was done literally in the last kind of 18 months. Multiple accounts of unclean accommodation infested with mice, rats, and bedbugs, which was particularly worrying for migrants living with their children. Respondents also described being placed in accommodation that was not suitable for their disability or having insufficient space to accommodate their children. And then there was a big concern about mixed housing between men and women, and mixed hotels as well, as many women and girls had experienced sexual and gender-based violence at the hands of males in authority or other migrants on their migration journey. And many of them spoke of bedrooms and bathrooms without locks, abusive staff who walked in unannounced, and also sexual harassment experiences. And being housed in these environments, having experienced sexual trauma and rape, meant many women were afraid and stayed in their rooms unless they had to use the bathroom. And it was reported that sexual harassment in the Home Office accommodation is quite hard to report and also not taken seriously. In terms of unaccompanied asylum seeking children, they're looked after by the local authority. They're essentially children in care. They should be provided with accommodation that's appropriate to preference and need, and they're subject to the National Transfer Scheme, which is similar to the dispersal policy, meaning they're distributed across the country after arrival. If they're under 16, they tend to be housed with foster families. And if you're 16 to 18, you tend to be in semi-independent living. And research has shown that children who are placed with foster families tend to have better outcomes in terms of their mental health. And thinking about refugees, so again, back to the fact that once you've got refugee status, you have 28 days to move out of any state-provided housing, which was associated with your asylum seeking status. But because of the reasons I've already discussed, many are unable to pay rent deposits in time, and they often end up homeless and destitute. There is emergency accommodation that is prioritised for families with children, but it's often unsuitable and unsafe. And then finally, undocumented migrants, they're the most vulnerable of all the groups. They're not automatically entitled to support, and it's a crime for landlords to knowingly let a property to disqualified persons, and often they experience overcrowding and frequent moves. Next slide, please. So in terms of health impacts, we know that overcrowding, cold, damp environments, and housing insecurity are all drivers of poor health, and poor quality housing has been linked to respiratory illness, accidental injury, poor mental health, vulnerable household relationships, and poor early childhood development. Next slide, please. So all child migrants in England have an implicit legal entitlement to attend school. However, administrative demands such as requesting proof of address, complex school admissions processes, and multiple moves mean this isn't happening in many cases. And a recent needs assessment I carried out of children registered with Bevan Healthcare identified that none of the children housed in one of the hotels were enrolled in education and hadn't been provided with any play or educational resources. And this lack of stimulation was a real concern for the clinical professionals looking after them, and particularly the health visitors who are worried about that early childhood development. This has since been resolved, but there'll be many other situations across the country where this is still a problem. And of concern, the Department of Education has a history of sharing personal details of up to 1,500 pupils a month with the Home Office for immigration control purposes. And that was a practice that had been adopted as part of the hostile environment agenda. And there's concerns that that history of sharing could deter parents from sending their children to school, with potential negative effects to their health and future life opportunities. And we know that there are positive health consequences for being enrolled in education. There's stable social support, it facilitates integration, it empowers children to be able to communicate in English, it enables their opportunities to have that early recognition of children in need so that they get the support that is required. It also gives access to school nursing service, so another point of contact for healthcare. And it provides children with skills and qualifications for future employability and financial security. And then conversely, lack of access to education, there's a lot of research that suggests it causes deterioration in mental health. Next slide, please. So despite potentially increased health needs, many migrants in England face barriers to healthcare access. So child refugees and asylum seekers and children looked after by the local authority and detained children are entitled to free, I think, have we missed a slide? Oh no, it's not missed a slide, no, you're fine. So entitled to free healthcare, but many others aren't. So, but also the expectation is that unaccompanied asylum seeking children get an initial health assessment within 28 days of registration with the local authority. There's no official health pathway for other refugees, asylum seekers, and undocumented migrants, but there is an expectation that their needs would be met at GP new patient checks. But because of barriers to registering with GPs and because of clinical inexperience in managing these population groups, often these needs aren't met. And so many experiences, asylum seekers and refugees, their first contact with the NHS is when they're acutely unwell, and therefore health professionals need to be holistic and opportunistic in their assessment of asylum seekers that they encounter. Next slide, please. So as I was saying, that all children looked after by the local authority, any detained children, if you've got refugee status or you're an active asylum seeker, you're entitled to free healthcare at all levels of care. However, undocumented child migrants and dependents of refused asylum seekers who aren't entitled to certain support are expected to pay their overseas visitor charging, and they're charged for certain hospital treatments at 150% of the NHS tariff, as Delan's mentioned. They can receive urgent treatment without advance payment, but fees are recovered subsequently. And if they can't pay debts of over £500, then their details can be shared with the Home Office and they can face detention and deportation. Next slide, please. So research demonstrates that healthcare user fees create a barrier to healthcare, even for those with entitlements. So service providers have difficulty understanding the complex policies and consequences have included eligibility mistakes and failure to provide urgent and immediately necessary care, irrespective of a patient's ability to pay. And Doctors of the World have published evidence on this as well. And there's also evidence that migrants are deterred from seeking healthcare as they're not certain of their entitlements, and they're really frightened of these unaffordable costs and bills for thousands coming through the post. And they're afraid of requested disclosures of immigration status and history of the NHS data sharing with the Home Office. However, we all know that failure to seek timely treatment results in worse health outcomes for patients and also often higher costs for the NHS. So there's no economic argument for this policy either. Next slide, please. So it's just to say that healthcare shouldn't be part of the hostile environment. As healthcare workers, we have a primary duty of care to our patients. Access to healthcare is a human right, and we've ratified treaties to say so. There are ramifications for public health if people are afraid to seek treatment for infectious diseases, for example, or they can't access the care or the immunisations that they need because of that fear. And as I've said, there's no economic argument for it either. Next slide, please. So thinking about barriers to healthcare, we've discussed the NHS overseas visitor charging. GP registration, as I've said, everybody's entitled to this, but many are refused GP registration because they can't provide addresses or identification, none of which is actually required to register with a GP. Language can be an issue. Interpreters aren't always provided. One mother was telling me how she called the GP during COVID when it was remote services about her daughter being unwell, but she wasn't often an interpreter, and she was really upset and anxious after the consultation because she didn't feel she'd have the language to explain the symptoms over the phone, and therefore she was really worried that the doctor hadn't been able to make an informed medical diagnosis and provide the correct treatment. So it caused a lot of stress for that mother as well. Culture is a big thing, and it's particularly relevant when we're thinking about approaches to mental health, and more research is needed in this area as different cultures will react differently to different mental health therapies. Digital exclusion, I've mentioned there's been this big move to remote services, but it often requires access to devices or credit and data to be able to access that. And health provider knowledge and emotional preparedness to also effectively manage this population. Access to specialist services can be a problem, sometimes because they might be geographically located somewhere very far away. It might be that the clinicians don't know what the referral pathways are, or it can also just be that people don't know that they exist, so they don't refer simply due to lack of knowledge. And obviously there are capacity issues and waiting lists across the NHS due to not being resourced well enough. So the last couple of slides, so what can you do? So in terms of addressing the healthcare barriers, next slide please. So you can identify the patient's entitlements and also make sure they're aware of their rights. You can be familiar with the RCPCH, the PHA or OHID and VMA guidance on assessment and management of refugees and asylum seekers, and I'll post those links in the chat. You need to be able to understand their life experiences and health needs and the correct technical and cultural approach to address these non-discriminately. Always use an interpreter where necessary and allow additional times for appointments. And it's really important to support migrants and their families to navigate the healthcare system and encourage engagement with service providers. Next slide, please. And also be an advocate. So Patients Not Passports Toolkit is an amazing resource to support advocacy against overseas visitor charging. And these points are pulled from a more detailed explanation of this on their website. So it's about challenging decisions by overseas visitors managers, checking whether people do or don't meet the charging exemptions. Because you yourself can say whether you think treatment's urgent or life-saving, so you can be the advocate in that respect as well. Inform patients of their rights, signpost them to support, and also it's something I feel particularly strongly about, make formal complaints on behalf of the patient and record that harm, because then we've got that evidence base to really fight this policy as well. Next slide, please. And then thinking about wider advocacy work. So we need to humanise child migrants through public speaking, media campaigns and engagement with policymakers. We need to work with lobbyists to convincingly frame policy issues to ensure their health is recognised as worthy of government attention and public support. And you can also engage with some great organisations doing advocacy work on this. So there's MedAct, Docs Not Cops and Doctors of the World UK as well. And you can encourage local GP practices to sign up to the Doctors of the World Safe Surgeries Network, which encourages inclusive general practice and supports practice to achieve this as well. And I think, next slide, please. I'm going to stop there because my last 2 slides are links, and it might be more useful for me to just drop those in the chat than to share them on the screen. So yeah, that's me. Thank you.
Thank you very much. Thank you, both of you. The talks have been very eye-opening, and I'm very grateful to have been able to listen and learn more about these things. I've had a fair amount of questions sent to me throughout the talks. Anyone can feel free to unmute themselves, ask any questions. And I'll just start us off by reading some of the questions I've had. So I've had a couple questions from medical students about what we can do to sort of do our bit essentially and help with everything. This is to both of you.
Yeah, I think it might have been that my last slide might have briefly covered some of that, but I think one of the key things is if being informed this early on is really good, because you'll take that forward into your clinical practice. But in terms of being advocates now, then I think getting involved, like lots of the universities have their own MedAct for students, and you can get involved with MedAct and lead on addressing some of these issues, and you'll get a lot of support from the national MedAct groups as well as that. And Patients Not Passports is the other group, as well as doing things personally, like writing to your local MP about, for example, that something that's happening now is they're looking at amending the Nationality and Borders Bill. If you Google that online, you'll be able to find out a bit more about that and challenge some of those issues. Dylan, did you have anything else to add?
I think I'd say something similar. There are lots of organisations working on this topic. Amy's mentioned MedAct, Doctors Not Cops, Doctors of the World. You know, we have within the RCPCH, the Royal College of Paediatrics and Child Health, within our own group, ICHG, there are people who are working to advocate for child health. So you can join any one of these groups, and that makes your voice much more powerful. You have a platform to work off. So yeah, I think that probably is the best approach.
Thank you. There was also a question about the sort of difference we've seen both in media portrayal and sort of overall attitude towards migrants coming from Ukraine versus other countries in recent years as well. And there's a question about whether you think that there will also be a difference in the healthcare they receive when arriving here.
I mean, I would hope not. Yes, so I think there's been a lot of talk and writing about this issue, how certain migrants are treated differently to other migrants. And this is not at all to diminish the situation in Ukraine. There are terrible things happening, and you know, really feel for the people there. But I think it's an argument about how all people should be treated the same. If someone is fleeing from Afghanistan, from Syria, for example, why are certain groups treated differently to other groups? And that goes to the slides Amy had about how migrants are portrayed, some of the slides I showed at the start, that certain groups, certain politicians portray migrants in very different ways. So I think in terms of the human rights documents, the laws, they're the same for any migrants. They don't make any difference. And we should have similar border policies for migrants. I fear that that isn't true, and you know, frankly, that isn't true. If we look at how other migrants are treated, if you think of labour migrants and how certain people are treated from certain countries compared to other countries, the overlap between xenophobia and racism, there's quite a big overlap. So xenophobia being a discrimination or an ideology against people from outside, whereas say racism around certain ethnic or racial groups, but really it's certain migrants who are discriminated against, not other migrants. I don't know, Amy, do you have more to add on that?
Yeah, no, I think you articulated that better than I would have done, but yeah, there's the same thoughts, and there's been quite a lot of conversations on social media as well about, you know, the issue of race, and how much that's played into the difference in the attitude, you know, the general public's attitude towards different, depending on the country of origin, the kind of different levels of sympathy or empathy for different groups. So it's, yeah, I think it's a really important thing to think about and reflect on as well.
Thank you. There's also been a question, are children who are forced to migrate more likely to experience neurodevelopmental delays? If, you know.
Do you have an answer to that?
I don't have an evidence-based one. I can give it. I have to say we do have a few children that we see, or that we've seen at Bevan, who have got suspected neurodisabilities. So that's not just neurodevelopmental delays. We're also talking about the whole spectrum of neurodisabilities, including, for example, autism. But it can sometimes be very difficult to unpick. So if children have experienced significant traumas, it might impact the way that they outwardly behave. And it might not be because of a neurodisability or a developmental delay. It might be a response to the trauma that they've experienced, or it might be because you're interacting with them in a different language that's alien to them, and which, or in environments that just aren't conducive to certain behaviours. In terms of development delay, thinking about the environments that some of the children are in, for example, in the hotels, and thinking further back through the migration journey in certain refugee camp situations, that not having that normal, secure environment. And we know that, you know, the first 2.5 years, how important they are for development, then I would suspect, but I'm not speaking based on that I know all the studies, I would suspect that their development would be impacted based on the trauma, the lack of stimulation, the lack of secure environment, and the lack of nutrition, all those things that we know are so important. But yeah, I'm not speaking with hard facts in my head, so don't, Delan, what you think about that?
Yeah, I'd say from a theoretical perspective, the conditions that children may grow up in these difficult situations where levels of pollution, toxins, and physical injuries from conflicts, and nutrition and everything else. So that would make you at a higher risk of developing all sorts of conditions, not just neurological ones. You know, if you're not vaccinated, you increase risk of infectious disease, which may have a neurological complication, and then you develop that. I don't have the numbers to back that up, like Amy was saying, but in theory, yes. But I think I probably have to look that up.
Thank you. There's also been a couple questions about whether there are any charitable trust or any schemes that can help asylum seekers with sort of healthcare costs and also oversee sort of payments and costs.
Just to say that asylum seekers, they shouldn't have any costs to their healthcare in the UK. So it's the undocumented migrants that experience the costs. So refused asylum seekers, for example, or people who've never applied for asylum. So Doctors of the World UK have a clinic service that they provide, and they are a charity. I don't know if I know any others that directly collect money to support, but I'm sure there probably will be. But Doctors of the World is the one that I know that do provide care for that population group, and will also, they have supported taking trusts to court when people have been charged phenomenal amounts of money or refused treatment based on their immigration status. But Delan, I don't know in terms of outside the UK as well. I mean, there's obviously UNHCRC and UNICEF, British Red Cross. They all provide the care in humanitarian settings, obviously outside the UK. But yeah, sorry, Delan.
Yeah, no, I'd probably say the same. So I was thinking Doctors of the World here, but if you're looking across the world than any of these humanitarian organizations, MSF, UN agencies, UNHCR. They would probably be the big ones. But there are lots of local charities, smaller groups as well in the particular locations.
Okay, thank you. There was a question on whether there is an online data set that records child migration.
I mean, I would probably go to the IOM datasets, so International Organization for Migration. It depends on which group. So if it is forced migrants, then UNHCR would be a better bet. If we're looking in terms of the UK, I don't know, Amy, you probably know better than UK setting which data sets are best.
The Office for National Statistics does publish figures on in terms of numbers of asylum claims and things, but also if you go onto the migration, if you just type in Migration Yorkshire website, they've got an interactive dashboard which has just been released this week, which is quite good, and you can look at areas across the whole of UK. It's not specific I don't think it's specific to Yorkshire anyway, so that might be, I don't know how specific it is to children, but it's quite a good interactive up-to-date dashboard to use as well.
Thank you. There was a question on how we can improve health provider knowledge and awareness about these issues we discussed today.
I mean, I think the simple answer is things like this. So at all levels of health professionals in medical school, amongst nursing students, amongst other health professionals, if we were to include discussions around migration as part of the normal curriculum, and I don't know, Daphne, you can talk to me about what happens in your medical school. I don't remember ever talking about this. We barely talked about public health, I think. And then within professional organizations, within groups such as ours and more broadly, it should be a normal part of medical education. And I think with other things, we now think about social determinants of health more than certainly we used to. It's a more usual topic of conversation. We think about climate change much more than certainly 10 years ago. Even now, it's one of the important determinants of health that people think of. But migration, racism, xenophobia, these factors, they're sort of peripherally there, but I think they need to be central in terms of medical education and clinical consultations as well. You need to know about your patients, where they are, what journeys they've been through.
Yeah, what I will say is in terms of my curriculum personally in my medical school, there really isn't anything that I can think of that has ever cropped up about any of these issues. There are sort of societies like Students for Global Health. There's a Doctors Without Borders Student Society. There's societies like that. And obviously the ICHG that you can get involved in, but there's nothing that's like a branch of the curriculum about these matters, which is quite surprising considering it's such a prevalent topic that gets talked about a lot. There are other things. So for example, I'm doing the Planetary Health Report card this year for my medical school, which is a sort of scheme to do exactly what we talked about, to try and encourage medical schools to implement teaching on these things in the curriculum. And it's written by students and then sort of published online on their website. And it's a sort of to try and give incentive to medical schools to start introducing more of these topics. But other than that, there really isn't anything that I've seen. I don't know about other medical schools.
And I think that's the key thing. It needs to be mainstreamed. It's not, it's wonderful that all of you have turned up to this talk, but I guess you are more interested in this topic. What we need is for all students, all health professional students, to learn about migration, about xenophobia, about these similar topics, because these are the most profound determinants of health. It's fine to learn the intricacies of anatomy and physiology, but just the conditions that someone may move through to get to your clinic have such a big effect.
Mm-hmm. there is a question on whether there have been any examples of successful interventions targeted to migrants to address health outcomes.
I mean, there are health systems that are more receptive to migrants. There are ones that have done, wonderful things. Thailand, for example, has included migrants within the health system. We see countries opening their borders. Poland is doing it right now to Ukrainian people. Lebanon has a huge number of migrants moved across the border. Pakistan with Afghani migrants. So we have countries that have taken in huge numbers of migrants and looked after them. Uganda is another really good example that's written into their policies. So this isn't that everything is bad and every group is bad. I think we can always look to improve, and the NHS has lots of wonderful aspects and parts about it, but particularly groups like undocumented migrant children are not looked after well within the NHS. We can improve that. And there are lots of local interventions, and maybe Amy, within the Yorkshire region, that the kind of things that you were talking about.
Yeah, I was going to say about the Doctors of the World Safe Surgeries initiative and network. So Doctors of the World provides training on how to be an inclusive GP practice. It explains what a patient's rights are to register, and just give tips on what could be done to support any migrants who are accessing your service. And I think they did, I can't remember the name of the organisation, but it did almost like a private shopper, what do they call, mystery shopper, sorry, a mystery shopper type exercise. Phoning up lots of GP practices across the country, trying to register as if they were an asylum seeker. And actually, although they didn't break it down by GP practice, the areas that were much more receptive were areas which have had a high proportion of safe surgeries in that areas. So it suggested that it does make a difference in terms of evidence for an initiative, that actually people were finding it easier to register once in areas where people had received the GP practices would receive the training, were much more aware. Because sometimes I think GP practices, and sometimes it's the admin staff, just thinking that is what the policy is. You have to, if you've not got proof of address, how do I know you're living in my area? How do I know you're entitled to this service? So they're just saying a blanket no, not necessarily understanding themselves that actually the NHS's policy itself is that you don't refuse somebody on the grounds that they can't provide the identification or address document. So I think safe surgeries is one to kind of encourage, if you're a GP, or certainly just encourage your own GP practice to sign up to. It's free to sign up for as well. It's at no cost to the surgery. And the other thing I'd just say in terms of increasing awareness amongst health professionals or students, health professionals, is trusts having the guidance accessible on their trust networks, because again, you can't be expected to know everything, and not everybody has an interest and will attend things like this. But it just means if somebody then encountered an asylum seeker or refugee, if there's just some links that are in places that are easy to find on a trust network, then straight away at least somebody has some bullet pointed things that perhaps they should be thinking about or screening for if it's the first time that asylum seekers presented to healthcare.
There was also a question on what the implications are specifically for children with disabilities.
I mean, I would say that there are implications at all stages of the migration process. And this is something we covered in part in the Lancet Migration report. Children with disabilities are often left out, left behind, so they may be the ones who don't migrate in the first place, and the ones who are sort of excluded from communities. And these are all forms of physical disabilities, learning difficulties, sometimes severe mental illness as well, that those people are excluded. And then within the migration journey, it's difficult anyway, but then if you are unable to walk, and if you have to, if you're in a wheelchair, for example, those things get magnified by huge amounts. And then when you arrive in the country, you need certain services, and you need medications and guides and other support measures. So I think at every stage it's more difficult and more support is needed for people with disabilities. It's often something that's not done well though, and those people are often excluded from services.
It's certainly been an issue locally. So we've had children arriving in the hotels who've got disabilities, and we've had to refer them into our local community paediatric or neurodisability services, for example, or disability services for the reasons. And the waiting lists are just huge as a new patient. Whereas if you'd have been born in the UK and a disability has been identified, you're already in that system. And the waiting lists are over a year long for some of these children. And the other issue is access to, if children have special educational needs and need to go to a school which can provide that, then that delay in them accessing education is even greater than for the other children who are already facing delays in access to education. So they really are particularly marginalised in terms of access to education and the healthcare that they need.
Thank you so much to both of you. I think that's the questions we have from the chat. I had a question myself. You both mentioned the sort of media portrayal of migrants and refugees in your presentations. And I think that's something that is quite frustrating, and you do see come up a lot in papers and articles, etc. And it really, I think, it has a huge impact on how people view migrants, and that in turn then has a huge impact on the policies and the care they receive, and whether they're allowed in the first place. And I was wondering if you both had any sort of ideas of like solutions to tackle that, because it seems to be such a problem that always seems to come up, but it's quite difficult to solve.
I'd love to give you an answer, and I don't have a very good answer. I think it's partly counter narratives. It doesn't have to be the negative stereotype that's given. If you look at the top companies in the US, so many of them are run by migrants. Google and Microsoft and PepsiCo was, I don't know if it still is, often from the same. I think there's 2 or 3 of the top American countries come from the same school in India. There are so many successful migrants, and so much of our health system is built on migrants who come here. And this is normal. People have moved and people always will. And improving the health system improves everyone. It's not about spending money on those people and taking it away from somewhere else. Those people contribute to the economy, and the economy grows. And you see so many countries around the world with low fertility rates and high life expectancy. The working age people are retiring. Think of Japan, Korea, for example, and they need migrants. These countries and economies can't survive. So there is a very different narrative that you can sell, which is very pro-migration. And some countries do better than others at that. I think there's always a degree of backlash when the homogeneity of a society changes, and that can be difficult. And it's difficult to argue against a particular circumstance. This person came here and took my brother's job. It's hard to argue the bigger effects of, well, actually there are 10 more jobs because these people came here. But I think, we can change these arguments. There are ways to do it. There are societies and groups that are doing that. The framing, this sort of way of presenting issues. So, I would sort of put it back on all of you. How can you advocate to improve child health in this discussion, but health more broadly for migrants? How could this be part of the work that you do? Because, we're not just seeing the patient in front of us. We need to think about everyone else out there too. Amy, can you give a better answer?
I can't give a better one. I think there's something about that power of a story, a person, sometimes you can argue statistics as much as you want, and statistics are important to support your arguments, but I think it's the power of the story. And I think a really clear example of that was how, you know, all the tabloid type headlines and anti-immigrant headlines, and then the picture of the boy washed up on the beach is what, I mean, albeit it was only for a week that the headlines kind of changed, but the power of that individual, despite the fact there'd been publications of how many people die in the Channel trying to get across, but I think individual stories are really powerful. So if you come across those, sharing them can be really influential. And I think as individuals, it's very difficult to change what the Daily Mail prints, but I think we can have influence within our own circles. And I'd imagine most of us here know at least one person who's got an idea in their head about immigrants and how they view them. And so I think it's about speaking out, countering misinformation, sharing the facts, and doing what you can within your networks, which hopefully then, you know, by other people talking about it. And I think some people, once they hear the awful circumstances of what the hostile environment policies do and mean, then suddenly it opens their eyes. And actually, sometimes it's just ignorance. People don't advocate or care because they don't hear the true story, because that's not something that the government's going to shout. Well, they do shout about it because they want populist support, but yeah, I think it's about just starting within your circles and working out, and then joining the advocacy group, which have greater reach to change some of those narratives.
Daphne, can I share just a couple of slides just about our group, which has the advocacy group within it? Ooh, what are you seeing? You're seeing Amy's presentation, aren't you?
No, we can see the slide.
Oh, I can't see it. What can I see? Yeah. So just for anyone listening, if you are interested, do have a look at the website, the International Child Health Group. As Daphne was mentioning, a special interest group at the Royal College of Paediatrics and Child Health. We have lots of different things going on. There's a very active advocacy group. So if you're interested in these issues, you can get like-minded people to work with. We have webinars such as this. We've got a mentorship scheme. There's a podcast. I spend most of my life doing that podcast, so do listen to the podcast. It's free for students for 1 year. Otherwise, there is a membership fee. But do have a look and see if it's something that might be of interest to you, because there are lots of people working on similar issues.
Thank you. I will say that podcast is really good. I have listened to every episode. Thank you so much, everyone. I don't see any more questions on the chat, so I think we don't have any more questions. But yeah, thank you so much, both of you. This has been a very, very interesting webinar. So thank you for giving up your time and doing it.
Thanks for organising it.